Many thanks, Yazan. I should, of course, credit you with the first paper on cut-off values and miscarriage, of course, part of your PhD. If you can still remember, it's a few years ago now, my friend.
Supervised by you, Tom.
Yeah,
So, and
well,
that paper, I must say, has really furthered my career, to say the least. So I'm grateful to you and to all the research group that was really brilliant in pushing this front in our specialty forward. Handing over to you now.
okay. Well, our next speaker, Thierry Vandenbosch, kindly giving up his time again. Thierry is the master of always wearing surgical blues just to look as if he's really busy. When this is actually has a set at home, and he's been working at home as far as I can see for at least the last 2 years. But anyway, never mind. So I think another area which I think is important, depending on the environment you work in, is safely managing miscarriage. Now, we don't see a lot of septic infections or associated with miscarriage where I work, but it is an issue in lots of parts of the world. So we're going to talk about safe management of miscarriage, including MVA and managing sepsis. And Thierry, who's at the KU Leuven in Belgium, if you weren't listening this morning, is going to talk to us about that, and hopefully we can have a chat with him later. Over to you, Thierry.
Hello. I will say some words about the management of miscarriage and septic miscarriage. I will first talk about the non-viable intrauterine pregnancy, the miscarriage, and then say some words on retained pregnancy tissue, and end with a few words on septic miscarriage. So first, talking about a non-viable intrauterine pregnancy, the first and important thing is to make the right diagnosis and to be sure that it's a miscarriage before you treat it, obviously. And therefore, I would strongly advise you to read Jessica Price's paper about how to diagnose, how to have to be certain that it's a miscarriage based on the absence of an embryo or a gestational sac measurements, and to follow this algorithm to be sure that it's a miscarriage before you even start thinking about treating it. What are the management options for miscarriage? Well, you may have the surgical option, doing a section aspiration, DNC. You have the medical options, mifepristone, misoprostol treatment, or you may just wait, and that's the expectant management. So what is the best management? Well, if you want to read it in detail, you can read the Cochrane review of 2021. It's 233 pages, but to summarize, and I was quite surprised of the results. They say that to achieve a complete miscarriage, if you have the diagnosis of an expelled pregnancy, the surgical methods seems to be the best, and the expectant management the worst. Of course, in this work, ultrasound, the use of ultrasound in the diagnosis and the use of ultrasound during evacuation was not assessed, so that might be important in the interpretation of these data. But also, when they looked at the serious complications, surgical methods had the least complications, and the expected measurement the worst. Again, ultrasound was not was used in these studies, and the complications were mostly heavy bleeding, cramping, and sepsis. But to put it in perspective, it depends where you are living when you have to choose the optimal management. And one point is the healthcare accessibility, and to illustrate that, because accessibility is defined as ease, with which health services are reached. When you look at the satellite photograph of the world, of this part of the world, you see Africa and Europe. And just looking at that, you can imagine that there is a difference in accessibility. And if you look at Europe, and I'm living at this hotspot where you have a hospital every 20 kilometers, of course, it is a huge difference as to the accessibility and as to the choice you will make how to treat the miscarriage. Another point is the psychological impact, is the patient choice, and it's important when you have a patient with a miscarriage to inform her, taking into account the accessibility in your country, taking into account the patient preference, and if it's possible to take that into account. And that's why when we look at our management of a miscarriage here in Leuven, well, when we see the patient and we make the diagnosis of a non-viable intrauterine pregnancy according to this strict criteria, we have a case manager discussing the options with the patient, and going from expectant management, medical therapy, and surgical therapy, and because the accessibility is quite high, and where I work, of course, expectant management is certainly an option, and most women in our center choose for medical therapy or expectant management. But in a country where the first hospital is at 400 cases, it is probably wiser to treat it with the surgical therapy straight away, because in case of bleeding, in case of sepsis, then you may have severe complications, morbidity, and even mortality. So it depends where you live, and it depends on the patient's choice. Some words about the manual versus electric vacuum aspiration for first trimester abortion and miscarriage. There is one systematic review, 2008, and well, to summarize, both are as effective and as acceptable in the management of miscarriage. They looked at the effectiveness of the complete abortion rate. There was no difference between the two methods. They look at the blood loss, and also here there was no difference in the blood loss during operation using the manual or the electric vacuum aspiration. And also looking at operation time, there was perhaps a slight tendency favoring electric vacuum aspiration, but it was not really a big difference. And the only statistical difference was the doctor's preference. So if the doctor can choose between a manual vacuum aspiration and electric vacuum aspiration, the physician will often choose for the electric one because it's more easy. But both are quite similar as to the efficacy. Okay, we move to the retained pregnancy tissue. So retained pregnancy tissue after an incomplete miscarriage, as we call it also. How do we diagnose it? Well, first of all, of course, you have the patient's history, the symptoms of the patient, and what are the ultrasound signs? Well, at ultrasound, it's not always that easy to see the retained tissue because it's not well delineated, so I think if you have a color Doppler, it is very, very useful because often you see some hypervascularity, not really of the inside the retained tissue, but in the myometrium underlying the retained products of conception. That's important, an important concept. Most of the vessels you see are in the myometrium and then are entering the retained products, but most are in the myometrium underlying the retained products. Here, to illustrate that, here you have a grayscale. You can see, well, you can imagine there is a retained products here. And at elastography, you don't have to do it as a routine, but we do it, and that's hard, and you see there's a blue spot here, and then you can see that that's the region of the retained tissue, and that the vessels that you see here are in fact myometrial vessels. So it's a enhanced myometrial vascularity in underlying the retained pregnancy tissue. And here we come to a concept that just some confusion. We are responsible because 25 years ago we published some work about the arteriovenous malformations, and I just want to tell you and to confess that 25 years ago we were young and we used the wrong term. It's not an arteriovenous malformation, so please don't use it if you're talking about enhanced myometrial vascularity that is pregnancy related. It's arteriovenous, of course, because that's just physics, but it's not a malformation. It's physiology, it's pathophysiology. These are the radial and spiral arteries that you see, and these are not malformed vessels. And that's important. That's important because an arteriovenous malformation is congenital, very, 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 very rare. Most, if not all, enhanced myometrial vascularity that you will see in your career are pregnancy-related enhanced myometrial vascularity and are not a malformation. And why is it important? Because if you see some enhanced myometrial vascularity, and that's in someone who has been pregnant recently, it's most likely to be retained pregnancy tissue. And if you remove the tissue completely, you will see the vessels disappear, and if there is bleeding, the bleeding will stop. Okay, that's the rule. That's the rule, and that's important. On the other hand, if you remove it incompletely, then it might start bleeding heavily and cause panic in the OR. Why? How to avoid a panic? Well, first of all, to do a good preoperative ultrasound with a preoperative mapping of where are the vessels, because if you know where the vessels are, you know where the retained tissue is, because it's just underlying the tissue that you see the vessels. And secondly, to do this procedure ultrasound guided. You don't need a high-tech, high-end ultrasound machine, but it's so easy to do it and so safe to do it with the use of a ultrasound machine. Okay, so that's pregnancy-related enhanced myometrial vascularity. Okay, and if you remove it, it will the patient is cured. Don't confuse with the AV shunt or AV fistule. That's a post-traumatic entity after operative hysteroscopy, other surgery, myomectomy. That's a fistule, nothing to do with pregnancy. That's another case of a big AV shunt here. We see the artery just flowing into this shunt. That's not pregnancy related, and it's also don't confuse it with enhanced vessels you see in gestational trophoblastic disease, as you see here. That's something else. Okay. And that's the algorithm used in the cases of retained products of conceptions with enhanced myometrial vascularity. You can read it. And we don't use embolization, almost never, but we use intrauterine balloon catheter in case of heavy bleeding. So if you have heavy bleeding even after your procedure, we just take a Foley's catheter, cut off the tip of the catheter, and then put it in the cavity, inflate the balloon, and in the large majority of cases, we can stop the bleeding and avoid embolization. And that's important for subsequent pregnancies. Okay, what I said till now, it's about non-septic retained products of conception, non-septic miscarriages, and there you can do whatever you want. If you will, you reach a shared decision making, and then you treat it accordingly, expectantly, or with surgery. A septic miscarriage is something totally different. That's an emergency, and that should be treated by antibiotics and surgical removal. Okay, septic miscarriage, we know it. It's may evolve in a couple of hours and leads to necrosis, to the production of toxins, to septicemia, and we know that septicemia can be very, very dangerous, can lead to septic shock, DIC, and death. So that's an emergency. And if you have a septic miscarriage, well, how to diagnose it? It's a clinical diagnosis. On ultrasound, well, sometimes on grayscale you may have some echogenic spots due to gas production of the anaerobic bacteria. On color, beware, sometimes you don't see any color because there is necrosis, and in necrosis you don't see, it's avascular, so that's a pitfall. And also when you do a vaginal ultrasound, and even if there is no site-specific tenderness on the uterus, beware of underestimation, because the patient may be that sick that she does not react anymore when you try to see if there is pressure-related tenderness. And the treatment is antibiotics, urgent surgical removal, and if you do the surgical removal, please do it under ultrasound guidance to avoid perforation, to improve the completeness of the tissue removal. That's key in septic abortion. And the ultrasound-guided intrauterine procedure, well, you can do it, usually we do it transabdominally, you feel the bladder to have a better view, and then you can see where you are in the uterus. You can also use the transrectal approach to have to do the ultrasound during the evacuation, but it's so important to do it under ultrasound guidance. Thank you very much.
Terry, thanks again for a great lecture. I always like this, how you cover this topic. I just want to ask you about this issue around what to do with retained pregnancy tissue, and whether or not to remove it, and the relationship between having retained pregnancy tissue or surgery and intrauterine adhesions. You know, what's your view on that? I mean, we very often see, people with a small amount of retained tissue ending up having, surgery when very often if they have a period or whatever, it just passes. On the other hand, does having that tissue actually cause adhesions rather than the surgery? What's your feeling about this?
The thing is,
I'm interested in Davil's view actually, because I know this is a topic he has a lot of expertise in. But anyway, Thierry.
I think the thing that reduces adhesions is infection. If you have infection, then you may have adhesion. So that's something. It's well, but if you look at studies with or without, well, if you have a retained products of conception and you don't do a DNC and you wait, or you remove it straight away, this does not seem to have a major difference as to adhesions. But providing that the patient present, if they have the symptoms of infection. So it depends where you live, and that's why in the Cochrane review they say that surgery is the best thing, because if you have a infection and you wait some days before going for surgery, then you will have a major problem. So it depends where you live, but yeah, I would like to hear the Davros opinion. I think I know what he will say, but there are studies who could not demonstrate the difference as to adhesions.
And you mentioned, we talked earlier about MVA and versus vacuum, or are there any criteria which you would apply if someone is going to introduce MVA in their practice somewhere? Would you say, gestational? Do you use gestational age? Do you have a view on size of sacs or anything like that? What's your sort of what are the limits you use?
The only thing is you have to be prepared that if you have a lot of vessels and it's high velocity vessels, it might bleed. So and the thing is, the faster you are in removing the tissue, and you have to be prepared to have to empty the bladder, to if it does that, to give some drugs to contract the uterus, and if the bleeding remains, we introduce a balloon catheter. It's quite helpful, we feel. And the thing is, in most cases, in the ground majority of cases, we do not use embolization anymore. And I think that's important, especially if you think of subsequent pregnancies, because after embolization, you may have more accretas and so on.
Okay, but I'm talking just your standard miscarriage who's going to have an MVA. You're not bothered about gestational age or size of the pregnancy or anything at all. You just get on with it. Is that what you're telling me?
But so you talk about the manual vacuum. I'm sorry.
If someone is trying to set up MVA and they're going to have an MVA set up and haven't come across it before, do you have any criteria that you use? No. You don't worry about gestation. You don't worry about the size of the pregnancy or if they're twins or anything. You think it's just get on with it. Is that what you're saying?
Well, the thing is, if you want to remove the bigger the embryo or the fetus, of course, so the more likely you will have might have major complications as to bleeding and so that's certainly an issue. If you have a big there are some people say more than 4 centimeters of pregnancy, that you have more complications.
So it'd be reasonable for people to be a little cautious when they start off, and as they get more experience, just to introduce that word of caution.
Yes.
One last question then: what antibiotics what are the antibiotics of choice in septic? And I'm going to say septic miscarriage because I know patients don't particularly like the use of the word abortion in this context, which gets I think we should change the wording. But anyway, what antibiotics do you use?
It must be broad spectrum because it's polymicrobial. So there are different bacteria causing the sepsis. So you have to cover the anaerobic and the gram-positive and gram-negative. So classically, you had the ampicillin and metronidazole and gentamicin. But nowadays, depending on your population, we use more amoxiclav and gentamicin, or you can also you have to have broad spectrum antibiotics just to cover all this.
Perfect. Okay, Thierry, thank you so much for a fantastic lecture. Thanks for all your contributions today. I'm very grateful. You can stop using your backdrop now and put your t-shirt on. Well done. And I'm going to hand back to Yazan to introduce the next speaker.
Thank you, Tom. Thank you, Professor Thierry.